Hi everybody, it's Mary, the OG Woo-Woo Therapist. And as usual, everything I talk about today is not intended to take the place of counseling or therapy, but to highlight some of the issues that could or need to be addressed with a licensed counselor or therapist. None of the information that I'm going to talk about should be used to self-diagnose or diagnose anybody else with a mental health disorder or any issues related to the topics that I'm going to talk about today. Only a licensed practitioner should be doing that. So today, before we start, I want to give the cautionary note. It's important to respect safety through pacing and supporting choice. That means I will move slowly. I'll explain concepts in a grounding way, and you're always invited to pause, skip ahead, or come back later. I encourage you to take the information in chunks. When people hear the word depression, they usually picture major depressive disorder, or MDD, and that makes sense, because MDD tends to announce itself very loudly. Major depressive disorder is an episode. It's like a heavy storm that rolls in, darkens everything, and makes it hard to function at all. The symptoms come on relatively acutely. Mood is markedly depressed or empty. Pleasure drops out of things that once mattered and suddenly don't. Energy, sleep, appetite, concentration, and self-worth all take a hit. And there's often a clear before and after. I wasn't like this last year, or I wasn't even like this last week. Episodes last at least 2 weeks, but can last for months. They are intense enough that people usually recognize something is wrong, or others do. Clinically, MDD is defined by severity. Dysthymia, on the other hand, or otherwise known as persistent depressive disorder, is not a storm. It is weather. Dysthymia, now called persistent depressive disorder, is a chronic low-grade depression that stretches on for years, where mood is consistently low, flat, or gray. Symptoms are milder than MDD, but never really go away. People often describe feeling tired, pessimistic, self-critical, and emotionally dulled, and joy isn't gone, it's muted. The key feature is duration of at least 2 years in adults, with no symptom-free period longer than a couple of months. Many people with dysthymia don't say, "I'm depressed." They say, "This is just how I am." Clinically, dysthymia is defined by persistence. A helpful metaphor we can use to think of MDD is falling into a deep pit, and think of dysthymia as walking your whole life with a heavy backpack on you that you forgot you were wearing. One is crushing and obvious. The other is exhausting and normalized. Functioning looks different with MDD and dysthymia. Someone with MDD may struggle to get out of bed, miss work, or withdraw completely, when someone with dysthymia often keeps going to work, parenting, showing up, but everything takes more effort and offers less reward. This is part of why dysthymia is underdiagnosed, because people are functional enough to survive, but not enough to thrive. Their depression is measured in degrees of how depressed they are, and looks like a sine wave of depression as opposed to a dichotomous representation like being depressed versus feeling good. MDD and dysthymia can coexist. Here's an important clinical point. It is possible to have both. This sometimes is called double depression, a major depressive episode layered on top of long-standing dysthymia. These individuals often say, "I've always been kind of low, but this is so much worse." And they're right. Treatment implications are that MDD treatment often focuses on acute stabilization using antidepressants, structured psychotherapy, and is focused on symptom relief. Dysthymia requires a longer-term relational and identity level approach by addressing entrenched self-beliefs, attachment patterns, chronic shame, and hopelessness. And there is usually a CPTSD trauma history. You are not just lifting mood, you are reshaping a life narrative. The thing to keep in mind here is that major depression knocks you down, but you can get up. And dysthymia quietly teaches you to live on your knees, always down. An important thing to keep in mind as we discuss this further are the concepts of polyvagal theory, of how the central nervous system keeps us safe. I'm just briefly going to review this right here. The body has a built-in safety system called the autonomic nervous system. It works automatically, just as the name suggests, without having to think about it. Its main job is simple, and that is to decide moment by moment whether we are safe, need to act, or need to conserve energy. This is called neuroception, and it is done below the level of awareness. The autonomic nervous system uses three main pathways for gauging safety. The first, the safe and connected pathway, are the ventral vagal pathway. This is the state your body uses when it senses safety. It is the pathway that supports calm focus, relationships, curiosity, and problem solving. Second, the action pathway, or the sympathetic pathway. This is also known as fight or flight activation. This prepares your body to act, to protect yourself, escape, or push through something difficult. It is not bad or wrong. It is a survival response. Third, the shutdown pathway, or the dorsal vagal pathway. This pathway helps the body conserve energy and reduce pain when it feels there is no way to fight or flee. Many trauma responses live here, not because something is broken, but because the body adapted to survive. A key thing to remember is that these pathways activate automatically below the level of awareness. They are not chosen, and they're not doing anything wrong when they show up. The nervous system learned these patterns to keep us alive, often very early and often very wisely. The fact that they are automatic matters in healing depression and dysthymia, because healing is not about getting rid of these responses. It's about helping the body recognize safety more often, gently widening the capacity to stay present, and learning how to move between states with more ease. With support, the nervous system can learn new patterns, not by force, but by experience. Now that we have that in mind, let us talk about how trauma shapes major depression versus dysthymia. When we bring complex trauma and attachment injury into the picture, the difference between major depression and dysthymia becomes less about mood alone and more about how the nervous system learned to survive. In people with CPTSD, major depressive episodes often show up as collapse states or dorsal vagal pathway responses. Not just sadness, but shutdown that brings emotional numbness, psychomotor slowing, withdrawal from relationships, and a sense of, I can't do this anymore. There is also increased suicidality or passive death wishes. These episodes are frequently triggered, even if the trigger isn't obvious, by relational loss, abandonment cues, perceived failure, and exhaustion after prolonged hypervigilance. From a trauma lens, MDD can represent the sympathetic nervous system saying, I can't do this anymore, I'm done. This is especially common in people who spent years functioning in survival mode, like being highly responsible, caretaking, or perfectionism, and it's done until the system finally crashes. Dysthymia, in contrast, often reflects developmental trauma rather than episodic stress. In CPTSD, dysthymia can be understood as a baseline survival state with chronic low mood, diminished vitality, muted pleasure, enduring self-criticism, and persistent shame. This is not just depression, it is a relational imprint. Many people with dysthymia grew up in environments that were emotionally neglectful, inconsistently responsive, chronically invalidating, and unsafe in subtle, ongoing ways. So the nervous system learns, don't want, don't feel, and don't expect help. Over time, that adaptation gets mistaken for personality, where we hear it said, I just have a depressed personality. This could not be farther from the truth. This is not personality. It is central nervous system adaptation. One of the things we must realize is that attachment patterns matter most with dysthymia. Attachment trauma shapes how depression feels. Avoidant attachment often pairs with dysthymia, as evidenced by emotional constriction, self-reliance to the point of isolation, minimization of needs, and I'm fine energy that is not actually fine unless you're using the acronym of I'm effed up, insecure, neurotic, and emotional. Then it is I'm fine energy. Anxious and or disorganized attachment more often precedes MDD episodes, as evidenced by intense relational distress, fear of abandonment, emotional flooding, and depressive collapse after attachment rupture. However, attachment is not necessarily causative. but can dictate the depressive response to situational issues. In CPTSD, these patterns can coexist, creating cycles of overfunction, which leads to exhaustion, which leads to depressive collapse, which leads to shame and becomes a repeat cycle. Now let us look at double depression through the lens of trauma. Double depression makes even more sense here. Dysthymia becomes the floor, and major depression drops through it like a trapdoor. Clinically, these are often people who say, I've never really been happy. I don't remember a time I felt good. And this episode feels familiar, but a lot heavier. Trauma did not cause the episode, it prepared the ground. For trauma-linked dysthymia, symptom-focused treatment alone can feel hollow. Medication may blunt pain but not restore aliveness. CBT without relational repair can feel invalidating because the core wound is not mood, it's connection, safety, and worth, which is reflective of attachment wounds in early childhood. This is why typical or conventional ways of treating depression are usually unsuccessful with dysthymia. What helps when looked at through a trauma-informed frame is long-term relational psychotherapy, attachment-focused work, somatic approaches, parts or ego state or IFS style work, and grief work for the life that should have been safer. The goal is not just feeling better, it is helping the nervous system learn, I don't have to survive this way anymore. Major depression is often a nervous system collapse. Dysthymia is what happens when collapse was never allowed, but only quiet endurance. Now let us look at MDD, dysthymia, and CPTSD with a trauma-informed formulation based on polyvagal theory. When clinicians hear depression, it's tempting to default to severity scales, episode counts, and medication algorithms. But in the context of complex trauma, depression often reflects state-dependent nervous system responses, not just mood pathology. From a CPTSD lens, major depressive episodes frequently represent dorsal vagal dominant collapse following prolonged sympathetic activation. These clients are often chronically hyper-responsible, relationally overfunctioning, emotionally vigilant, and externally competent. Depression emerges after attachment rupture, perceived abandonment, cumulative exhaustion, and loss of meaning following survival-driven identity, or a breakup. Clinically, this looks like MDD, but trauma-wise, it is protective shutdown. Treatment implications for dysthymia are that early phases should prioritize stabilization and nervous system regulation, not insight. Behavioral activation may need to be titrated carefully to avoid reinforcing shame. EMDR exposure or trauma memory processing should be delayed until collapse resolves. And relational safety in the therapeutic alliance is central because the client is often braced for disappointment. The clinical task is not to push function, but to support gradual reemergence. Dysthymia in CPTSD is often better conceptualized as a trait-level adaptation to chronic relational misattunement or caregiver failure to meet safety needs, as described on the first level of Maslow's hierarchy of needs. These clients learned early that needs are burdensome, joy invites disappointment, and hope is unsafe. Their affect is constricted, not chaotic. Their despair is quiet, not dramatic. They often present as compliant, self-effacing, easy clients, and emotionally distant from their own experience. Treatment implications here are that symptom reduction alone can feel hollow or invalidating. Cognitive restructuring may inadvertently reinforce self-blame, and progress is measured less by mood elevation and more by increased vitality, agency, and desire. The long-term work often requires attachment-focused therapy, parts ego state work to access disowned needs, grief work for unmet developmental experiences, and slow cultivation of pleasure and wanting. The therapist may be the first sustained witness to the client's inner life. Let us look at this case illustration of the collapse pattern involved in MDD and CPTSD. Alex, who is in their late 30s, presents with the first major depressive episode following relational loss or a breakup. Their history reveals childhood emotional parentification, where they became more like the parent as a kid, has high achievement, and a limited tolerance for dependency. What is indicated here is prolonged sympathetic dominance, attachment rupture triggering dorsal collapse, and shame around not coping. What we need to focus on in treatment is pacing and containment, explicit normalization of collapse as adaptive, resourcing and relational attunement before trauma processing, and cautious use of antidepressants as supportive, not curative. Here is an illustration of the endurance pattern we see with dysthymia and CPTSD. Maria, they are in their mid-40s, reports lifelong low mood without discrete episodes. Their history reveals emotional neglect, chronic invalidation, and early suppression of need and desire. What we see here is baseline affective constriction, internalized relational hopelessness, and identity organized around endurance. Our treatment priorities would include naming dysthymia as adaptation, not defect, expanding affective range rather than chasing happiness, parts work to protect emergent desire from internalized shame, and relational repair through consistent attunement over time. One of the things we need to look at and get an understanding of is attachment patterns as differential indicators. Attachment organization often predicts depressive expression as an avoidant attachment that leads to dysthymic presentations like constriction, self-sufficiency, muted affect, and anxious or disorganized attachment leads to episodic MDD like relational triggers, affective or emotional flooding, and collapse. Many CPTSD clients oscillate between the two, resulting in double depression. Here, dysthymia forms the baseline, and MDD represents episodic decompensation. Treatment-resistant depression, I'm sure that all of you have heard of that at some point, is often a misnomer because we're not looking at depression as a mood disorder, but as organizational survival and trauma. When trauma and attachment injury are unaddressed, we see medication plateaus, self-management skills feel mechanical, and clients report functioning without aliveness. The depression is not resistant, it is protective. Effective treatment requires shifting from asking, how do we reduce symptoms, to what does this system need in order to feel safe enough to live? To sum up, major depression with CPTSD is often collapse after prolonged survival. Dysthymia is survival that never had permission to stop. Treatment is not about forcing light into darkness, it's about building enough safety for light to emerge. When viewed through the polyvagal theory, depression in CPTSD is less about mood disorder and more about autonomic state regulation. Rather than asking, why is this client depressed, the more useful clinical question becomes, which vagal state is organizing this presentation and why? In CPTSD, major depressive episodes frequently reflect dorsal vagal dominance following prolonged sympathetic mobilization. The sequence often looks like this. There is chronic sympathetic activation, hypervigilance, overfunctioning, relational scanning, attachment rupture, cumulative stress, with dorsal vagal shutdown or collapse, numbness, anhedonia, and withdrawal. Clinically, this meets criteria for MDD. Neurophysiologically, it is energy conservation and threat immobilization. Common dorsal markers are psychomotor slowing, flattened affect, cognitive fog, diminished interoceptive or internal awareness, and passive death wishes rather than active suicidality. Treatment implications from a Polyvagal-Informed perspective would avoid interventions that demand rapid mobilization, would prioritize ventral vagal cues like tone, pacing, eye contact, and rhythm, track microshifts in energy rather than symptom elimination, use co-regulation before self-regulation, and delay trauma processing until ventral access is reliable. The goal is emergence, not activation. Dysthymia in CPTSD often reflects a long-standing autonomic compromise rather than episodic collapse. These clients may not be fully dorsal vagal, but they are functioning below ventral capacity. Polyvagally, this looks like a narrowed window of affective or emotional tolerance, reduced ventral vagal tone, blunted sympathetic mobilization or low fight or flight response, and chronic low-level dorsal vagal influence. Affect is muted. Desire is faint. Hope is not absent. It is inaccessible. This state develops most often in context of early emotional neglect, misattuned caregiving or not meeting the needs of the child, and lack of safe co-regulation in childhood by primary caregivers. The nervous system learns to stay small, stay quiet, don't expect rescue. Treatment implications are not to frame this as resistance or low motivation. Interventions should focus on gradual ventral expansion. Pleasure, play, and curiosity are good clinical tools here, not add-ons. We must keep in mind that progress may initially increase grief or anxiety as aliveness returns and long-term relational consistency matters more than technique. Let's revisit the case of Alex with illustration of polyvagal collapse as major depressive disorder and CPTSD. Alex presents in a major depressive episode. Polyvagal formulation is prolonged sympathetic dominance masked as competence and attachment rupture or a breakup triggering dorsal shutdown. The way we would treat this is by slow session pacing, grounding through sensory orientation, therapist-led regulation through voice, posture, and rhythm, naming collapse as protective to reduce shame, and careful titration of behavioral activation. Medication may support reentry, but ventral safety enables it. Now let's revisit Maria and the case illustration of polyvagal constriction with dysthymia and CPTSD. Maria presents with lifelong dysthymia. The polyvagal formulation would see early absence of ventral co-regulation, default to low energy, low expectation states, and identity organized around endurance. The clinical strategy would be to build ventral experiences in session, track moments of interest, warmth, or expansion, protect emerging desire from internalized dorsal shame, and work with parts that fear hope is dangerous. Here, treatment is not about lifting mood, it's about restoring physiological permission to want. Many times I hear my clients talk about hope not being a thing for them because it will just end up in disappointment. And treatment is the way to build the ability to think about being hopeful without being afraid of it. Another thing that can happen is where both types of depression are co-occurring, otherwise double depression. Let's look at double depression through the polyvagal lens. In CPTSD, dysthymia often represents the baseline autonomic set point. Major depressive episodes occur when sympathetic effort exceeds capacity and dorsal shutdown becomes total rather than partial. This explains why some clients say, I've always felt low, but this is different. They are correct. The nervous system has crossed a threshold. I have a client who has dysthymia and recently went through the long-term debilitation and eventual death of her mother. She fell through the trapdoor of a major depressive episode with the death, but not the illness. Coping with her mother's illness was par for the course with the dysthymia. The relational loss pushed her into the MDD episode. Modality selection from a Polyvagal-Informed perspective would include somatic therapies to restore interoception or internal awareness and state awareness. Parts work to map autonomic states to parts and protective strategies. We can use EMDR, but EMDR is effective only when ventral access is established. We would use attachment-focused therapy, which provides ongoing co-regulation. And in some cases, medication, which supports capacity, does not resolve automatic patterns. Depression and CPTSD is not a single disorder. It is a map of autonomic survival. And treatment succeeds when we stop asking clients to feel better and instead help their nervous system learn that connection is no longer dangerous. Here is a common clinical misstep, and that is when treatment stalls in CPTSD-related depression, it's often not because the intervention is wrong, it's because it's mistimed for the client's autonomic state. With dorsal vagal shutdown or major depressive collapse, freeze, and numbness, polyvagal markers would include flat or slow voiced, limited eye contact, psychomotor slowing, cognitive fog, I don't know responses, passive death wishes, and the body feels heavy or distant with depersonalization or derealization. Common clinical missteps with this would be pushing behavioral activation too early, assigning exposure or trauma processing too soon, interpreting disengagement as resistance, over-relying on insight or interpretation, and challenging distorted cognitions. This backfires because the nervous system is conserving energy and mobilization demands are experienced as threatening. Instead, we would slow the session down, use our voice, rhythm as pacing as regulation, name shutdown as protective, track micro shifts in sensation or energy, and focus on co-regulation before self-regulation. The thing to remember here is that you can't reason a nervous system out of a shutdown. Sympathetic dominance with agitation, anxiety, and trauma-driven depression indicated by polyvagal markers would be rapid speech or pressured storytelling, restlessness or tension, catastrophic thinking, emotional flooding, and difficulty pausing or reflecting. Common clinical missteps here would be adding more coping skills, encouraging catharsis without containment, moving too quickly into trauma narrative, framing activation as motivation, and ignoring relational triggers. This backfires because sympathetic systems don't need more energy, they need containment and predictability. So instead, we would interrupt gently and slow the pace, orient to the room and present moment, reduce cognitive load, emphasize boundaries and limits, and support titration or letting go of emotion rather than expression. The thing to remember here is that more processing isn't always progress. Now let's look at chronic ventral deprivation as we see with dysthymia. Here we have emotional constriction and attachment trauma. The polyvagal markers would be polite affect, consistent attendance with minimal emotional range, difficulty identifying wants or preferences, low vitality, low curiosity, and I'm fine without resonance or the I'm fine energy. This is how most of my clients present. I remind them that unless they are using the acronym, I'm pretty sure they're not fine, and let them know that it's okay to say, I don't know. Common clinical missteps here would include setting mood-based goals, expecting insight to produce change, over-validating endurance, moving too quickly into trauma work, and mistaking compliance for safety. This backfires because the system has never experienced sustained ventral states or gotten off their knees. There's no physiological template for feeling better. So instead, we track moments of warmth, interest, or softening, use relational attunement as intervention, introduce pleasure and play slowly, normalize fear of hope, and expect grief as ventral capacity increases. The thing to remember is that you can't activate joy in a system that never learned safety. The goal with polyvagal interventions is ventral vagal emergence, which is evidenced by early childhood healing and increased aliveness. Here, the polyvagal markers are increased affective range, curiosity and spontaneity, new desires or boundaries, and anxiety or grief alongside relief. The grief that comes with this process is often the grief for the life that they never had. Common clinical missteps here are interpreting distress as regression, accelerating trauma processing, reducing support prematurely, ignoring backlash parts, and over-celebrating without containment. This backfires because aliveness can feel dangerous in trauma-organized systems. Here, instead, we normalize mixed affect, protect emerging parts, pace gains deliberately, maintain relational consistency, and address internalized fear of hope. The thing to remember is that healing doesn't feel safe at first. It feels unfamiliar. In conclusion, the thing to remember is that most therapeutic ruptures in CPTSD depression are state mismatches, not technique failures. When we match the intervention to their autonomic readiness, clients don't just improve, they stabilize, they integrate, and they stay. This is the nature of healing depression and dysthymia and CPTSD. There is hope, and learning that being hopeful is not to be feared over time is how hope and healing happens. Well, that's it for today. I hope you got a lot out of the content today. If you did, please give it a like and subscribe. I will be back next week with another topic of interest in working with CPTSD and dissociative disorders. If you would like to engage in discussion about any of the topics, please look me up on YouTube and engage in the community conversation, or go to my website at https://www.theogwoowotherapist.org. Thank you for being here, and I'll be back next week with another client-suggested topic.